Okay, good afternoon, everybody. My name is Dr. Jeff Calvert. I'm with the World Trade Center Health Program at NIOSH, part of the Centers for Disease Control and Prevention. And it's my pleasure to serve as the moderator for today's fourth installment of the Clinical Best Practices of the World Trade Center Health Program. And today the topic is diagnosis and treatment of chronic rhinosinusitis. And we have two eminent speakers who will be presenting this material today. First, we have Dr. Rafael E, who is a pulmonologist, occupational medicine specialist, internist, and professor who practices at the Icahn School of Medicine at Mount Sinai. And we have Dr. Michael Shohet, who is an assistant clinical professor of Otolaryngology and head and neck surgery at the Icahn School of Medicine at Mount Sinai. And then we have a few disclaimers. First, the views expressed in this presentation are those of the speakers and don't necessarily represent the official position of NIOSH CDC. Mention of any trade names, commercial practices, or organizations do not imply NIOSH or CDC endorsement. And citations to websites external to CDC NIOSH do not constitute our endorsement of the sponsoring organizations. Furthermore, we're not responsible for the content of those external websites. Next slide. We have one disclosure from Dr. Delahose, which has been mitigated. Those are my opening remarks, and now I will hand it to Dr. Delahose and Dr. Shohet. You can start sharing your screen.
Good afternoon, everyone. All right, so we are going to discuss the World Trade Center Health Program best practices for diagnosing and treating chronic rhinosinusitis. And this is based on a short manuscript, very readable, that is in the archives of environmental and occupational health. Details will be provided for those who may not have them already. Next. So as an introduction, in clinical practice, chronic rhinosinusitis is very often overlooked, and many people do not realize that it is a very broad public health issue. Probably 1 in 8 Americans have chronic rhinosinusitis in one way or the other. The estimated healthcare costs are in the range of 8.6 billion in the United States, at least by one estimation. And studies that have been done on quality of life have shown that CRS has an adverse impact that matches that of several major chronic medical conditions such as CHF, COPD, and others. Next. In the World Trade Center exposed individuals, survivors, and responders, CRS is the most commonly reported adverse health effect and certified condition. About 30% of the members of the health program are certified for CRS, so it is not trivial. Next. So it has been long known that occupational and environmental exposures to both allergenic and non-allergenic air toxicants and pollutants can contribute to the development and worsening of chronic rhinosinusitis. Next. So a variety of methodological limitations, however, have precluded an estimation of the population attributable risk in the medical literature. Next. In occupational CRS and other upper airway diseases very frequently precede and or coexist with occupational lower airway disease. In other words, most of the times when there are the two conditions, CRS precedes or happens at the same time. If it happens after, is suspicious of not being related to the exposure. And the other fairly well-established fact is that occupational CRS incidence substantially exceeds that of occupational lower airway disease. Next. So CRS was very often associated with disease at the pharyngeal and laryngeal level and probably accounted for most of the reported World Trade Center cough, for those who may remember 20 years ago when that was the term that was used. CRS and upper airway disease contribute also to comorbid disease symptom worsening, for example, worsening of symptoms of lower airway diseases and of obstructive sleep apnea. Next. As of December 21, as I said, 30% of all W2CHP members were certified for CRS. And there is some evidence in the medical literature that supports the association with World Trade Center occupational exposures, although most of the associations have been modest in size and also not fully replicated in all cohorts. Notably, the presence of atopy in the World Trade Center exposed workers, whenever it has been studied, and most studies have been small, does not seem to exceed that of the general US population. So it's not because this was a selectively more atopic or allergic population that this has happened to them. Next. Another issue with terminology is that rhinosinusitis as a term emphasizes the continuing inflammatory findings throughout the sinonasal mucosa, from the anterior nares to the nasopharynx and including all paranasal sinuses. So, and acknowledges the fact that frequently the presenting symptoms are overlapping for when all of these levels are affected. Despite this consensus terminology favoring this choice, some specialists that you will work with and come across may prefer to separate chronic sinusitis from chronic sinusitis, rhinitis from sinusitis, or from CRS. In some cases, we can, even accepting these consensus terminology, one may conclude after very careful evaluation and follow-up that somebody has predominantly chronic rhinitis versus chronic sinusitis. But in general, the term that encompasses the entire sinonasal space should be preferred. Next. So for the purpose of the best practices, we were asked to identify a guideline in which selected this one, evaluated it, and felt that it provided the most comprehensive, updated, and evidence-based guidance on CRS diagnosis and treatment. And the flow chart that you are going to see is a reflection of some of those recommendations. So nasal mucosa is the first interface with inhaled irritants or toxins or allergens. Next. So patients with CRS in need of surgery, in particular patients in need of repeated surgeries, are more likely to have been exposed to inhaled noxious agents at work than comparable controls. A number of agents like paper dust, cleaning agents, metal dust, animal proteins, moisture, molds, mildew, and remain independently associated with CRS. Next. So upon occupational exposure and inhalation to certain dust or aerosols, there can be next loss of olfactory acuity, atrophy of the nasal mucosa, nasal ulcers. All of these have been described, even nasal septal perforations with specific agents, nasal mucosal dysplasia, granuloma formation, and even sinonasal cancer. There are several agents that are occupational sinonasal carcinogens. So this is the Icahn Rhinosinusitis document. That is the beginning of it. That says it's 500 pages and 2,500 references. Next. And so we decided that it was most practical to really try to make it converge into a flow chart that it will illustrate the approach to the management and diagnosis and treatment of these patients. So basically, from a number of symptoms like obstructions, anterior, posterior discharge, sneezing, nasal itching, dryness. Next. one would pay a specific attention to identify anything that would be unusual, alarming, or indicative of probably serious comorbidities, or if the patient has presented after failure of adequate medical treatment. Often they have not been treated properly. And if all of those are absent, it is reasonable to begin treatment with saline nasal irrigations and a trial of a topical nasal corticosteroid. Next. And consider, characterization of the clinical features, including allergy testing, whether that be by RAST or by a skin test, peripheral blood eosinophil, pheno, that other number. And based on the findings, if somebody has allergic disease or not, consider addition of other medical therapeutic agents based on that. So if it is a person who is allergic, leukotriene modifiers or antihistamines, whether topical or systemic, are reasonable. Whereas if the person is not allergic, the antihistamines actually still work because they have an anticholinergic effect, or oral decongestant may be added, at least in short term, to try to improve the symptom control. Next. And if the treatment is successful, of course, you continue that. In the case of, on the right side, of the allergic individuals, consideration may be given to immunotherapies. There's a clinical indication, and particularly if there is no contraindication. Next. If there is a failure of medical treatment, that is when you consider an intensive anti-inflammatory plus minus antibiotic treatment, or an evaluation by an otolaryngologist and or a sinus CT scan. I wanted to emphasize that you would go to this first step if at the beginning, at the top, you identified alarm symptoms. At presentation, the individual had unilaterality, excessive pain, disproportionate, bleeding, any signs that could suggest severe structural problems or even malignancy, you would expedite that evaluation by otolaryngology and or, as I said, imaging to establish what the situation is. The medical treatment that I discussed before is in the absence of those alarm symptoms. So after that evaluation, usually you get a report that basically tells you two things, but whether there are significant anatomic problems that are correctable with surgery, or if there is a lack thereof. If there are correctable anatomic problems, it is at least a consideration to proceed to surgical intervention. And if there is not, or even after that surgical intervention, at the very bottom, it is important to emphasize to patients that chronic rhinosinusitis is a chronic inflammatory disease, and that the medical treatment is very likely to be needed after the surgery. And if there hasn't been surgery, well, it's continued. And among the modalities that may be added, again, immunotherapy is a consideration. And right now we have available a number of biological agents, anti-IgE or anti-interleukin agents that can be considered for the treatment of complex cases. So that's the summary of these flow charts. We have a case presentation. Is a World Trade Center worker, was in 2010, she was 48, and she was a police lieutenant, a lifetime non-smoker who had come first to the screening program in 2003, but got lost to follow up for almost 7 years and was treated in the community. Next. And so she had been in the downtown area for about 5 weeks approximately. She ended in October 2001. And because of, next. repeated asthma episodes. She was being hospitalized to twice every year at several hospitals in the city of New York. Never intubated though, but treated with oral corticosteroids and hospitalized, as I mentioned. And she was on treatment with an inhaled corticosteroid and a short-acting bronchodilator, but with partial control and frequent exacerbations. Next. So just to go over some comorbidities, just to get them out of the way, because these things don't happen in isolation, and particularly in the World Trade Center workers. She had heartburn, and she had a hiatal hernia, and she had been treated with antacids. Next. And she was a severe snorer. Realized that snoring is a very common symptom of chronic rhinosinusitis. And she had a little bit of daytime somnolence, which chronic rhinosinusitis can also produce, by the way. And she had a polysomnogram that, despite her low BMI, which you can see there, exceptional for the World Trade Center population, she was diagnosed with minimal to mild obstructive sleep apnea, mostly positional, and that was reconfirmed and more recently in 22. Next. But going back to her rhinosinusitis, she reported that she had pre-existing disease, but she had experienced significantly worsened nasal obstruction in anterior and particularly posterior discharge since 2003, and that it was perennial with seasonal worsening and upon exposure to house dust. We were unable to find anywhere in the chart or from history whether she had any aspirin sensitivity. And she admitted to some clutter in her bedroom. She had implemented some house dust avoidance measures, but there was no clear evidence of formal diagnosis and steady medical treatment for rhinosinusitis between 2003 and 2010. Next. So you see here from the flow chart, that the first thing is to try, there were no alarm symptoms or serious comorbidities, or and that we couldn't quite say that she had failed medical treatment. So a trial of saline irrigation and topical corticosteroids was indicated. We determined that she was atopic, and adding leukotriene modifier and topical antihistamine as elastin. But because of, actually it was prompt, I'm a pulmonologist, so because of difficult to treat asthma, we tend to look for comorbidities that could be subverting the control of that disease. So I actually decided to send her for a sinus CT scan and for ENT evaluation, and to see if she had those anatomic problems that could be addressed by surgery. And as I said, she had elevated IgE significantly and evidence of sensitization by RAST, and the evaluation. The sinus CT scan was actually done first in September, and it showed, as you can see, one of the concha bullosa is a pneumatization of the inferior turbinate that makes it extremely large, and in her case, it's even abutting almost a deviated, if substantially deviated nasal septum. She had filling of several ethmoid sinuses. The maxillary sinus, the left one, is very opacified, and and several of the ethmoids, as I mentioned. So she had substantial sinusitis, and when she was seen by the otolaryngologist at that time, there was also evidence of nasal polyposis, not severe, but definitely present, and some evidence of edema, intererythenoid edema on rhinolaryngoscopy. And she was treated intensively with 3 weeks of treatment of antibiotic or corticosteroid, nasal elastin. But despite symptom improvement, the CT still showed that left maxillary sinus opacification, and surgery was offered and performed in early 2011. So she really experienced some improvement. And just fast forward to when I saw her really in June of 2019, and I was consulted because she had very highly variable lung function on high dose inhaled corticosteroids, I'm meaning extra doses of corticosteroids and frequent short-acting bronchodilator use, both inhaled and nebulized. And upon questioning her more, I realized that she had those persistent symptoms. She tended to underestimate them or underreport them. She said that it was less than 3 days a week. But she had not been on a nasal corticosteroid. I implemented that. And she certainly did not like to perform nasal irrigation, which happens with some patients. Next. So, she had been on Montelukast, but mostly because of her asthma, and occasionally used fexofenadine, but tended to use it with decongestant because of symptom exacerbation. And as I said, asthma was not well controlled. So in that CT scan that we did, there was this time filling of the sphenoidal sinus. So that was a site that had not been addressed with the previous surgery, and the left maxillary and the maxillary sinuses are relatively open, and there was also a mild polypoid maxillary sinus mucosal thickening. So at that time, again, next. Next. There was surgery was actually offered. There was some inspiratory flow limitation, and she was also evaluated by laryngology, had some muscle tension dysphonia, which can give some impaired ventilation. And next again. And from here, I'll Dr. Shohet will take over to explain what he as a specialist does, and take it away, Michael.
Well, thank you, Rafael, and thanks for that great introduction. And I'd like to also extend my gratitude to Dr. Calvert and the team at CDC NIOSH and all the great work that's being done there. So usually I come into the equation somewhere toward the bottom of that flow chart that Dr. De La Hoz had outlined earlier. So I want to go over what a patient may be exposed to when they are referred to an otolaryngologist. As you know, most patient experiences and most patient referrals are not clean. For instance, the patient that Dr. De La Hoz had mentioned, she had seen prior otolaryngologist before she came into my care. So I was involved in her second operation, but I wasn't involved in her first. And things like that very often happen. So it's not always one specific team following this patient longitudinally for 20 years. It's very often different teams at different times, but I'm always there and I'm always helpful to enter the fray at any time. So most of you already recognize what a rhinolaryngoscope is. They used to be flexible fiber optic scopes, and in fact, some people still use those. Most of them now are distal chips, so they're actually just digital, where the camera is at the very tip, and the rest is simply a way of navigating the scope in the patient's upper airway. We'll very often give the patients inventories. The ones in particular that are helpful for me, both managing these people longitudinally to see how they respond to certain interventions, is the SNOT 22. That's the one that I use. There's actually a more updated SNOT 25, which includes some empty nose quality of life symptoms as well. It just gets very long once you get too many questionnaires. And the nose scale, which is a very simple, quick, and easy one, and definitely one that we give patients pretty much at every visit. Fair game for my exam is obviously the external structures of the head and neck. So the scalp, the face, the ears, the nose and the soft tissues of the neck, but we also look intranasally as well. So we're looking at the mucosa, the quality of the mucosa of the nasal cavity, both the nasal septum and its configuration, the outlines of the middle turbinates, into the nasopharynx, and even beyond to get a good look at the larynx as well. This is just to show you what we can see with anterior rhinoscopy. Very often you can see into a patient's middle meatus with anterior rhinoscopy, especially if they've received decongestant. This is kind of a zero discrete view of anterior rhinoscopy. So the scope is not in the patient's nose here, it's just outside and looking in. So you can see the inferior turbinate pre-decongestant, and then you can see it post-decongestant on both sides to get an idea of what a topical decongestant can do for an examination and why very often when people are referred to otolaryngologists, that's part of the exam. This is kind of a video of what we would encounter in somebody with chronic rhinosinusitis. You see more friable mucosa, you see thickened, irritated mucus and mucous membranes. We do like to take a look in the back all the way to the nasopharynx as well. On the contralateral side, we see an obstructing nasal septal deformity with contact points and friability of the mucosa. So just very briefly, because chronic rhinosinusitis is an extremely complex thing, and obviously the goals of this discussion are not to discuss every single type of chronic rhinosinusitis and how to treat it, but I think it's important for most people to understand that there are different phenotypes, and each of those phenotypes does warrant a different approach and different treatments. So I wanted to very briefly go over the different types and what one may encounter with dealing with those. So very common ones are chronic sinusitis with or without polyps. The presence of polyps can sometimes, but not always, indicate that there may be a component of allergy or atopy, but there are certainly patients with chronic rhinosinusitis with polyps that do not have IgE-mediated entities. Very often their serum eosinophil counts may be high, or the mucin associated with those polyps will be rich in eosinophils too, which suggests that there is an eosinophilic component to a lot of those cases as well. Now, these patients with chronic rhinosinusitis very often will have baseline symptoms along with what Dr. De La Hoz had mentioned earlier. So about 12 weeks of nasal obstruction, postnasal drainage, sinus pressure. And those are just background symptoms that may or may not be bothering them. A lot of times these people have just been suffering for so long that if they're in that chronic quiescent stage, they may or may not seek help. Maybe they have things under control because they're already using a sinus rinse or topical nasal steroids. But then those people are still prone to develop acute exacerbations, either by exposure to other irritants in certain populations or to viral upper respiratory infections. They can be particularly vulnerable to allergy exacerbations and the like. So those are the people with recurring acute exacerbations of chronic rhinosinusitis. And very often that may tip the table to consider surgical management for a certain percentage of the population here. And then that's not to be confused with acute sinusitis, which is not a chronic rhinosinusitis. It's not part of this talk, but I can guarantee that many of you see people in your practices that don't have chronic rhinosinusitis, but either every time they get a viral upper respiratory infection, the symptoms linger just a little bit longer, or maybe there's a second peak where they think that their symptoms have gone away, and the next thing you know, they have this purulent nasal drainage or facial pain and pressure. That is the acute rhinosinusitis. And some of these people have so many anatomic issues that predisposes them that it'll become recurrent acute rhinosinusitis. And there are different interventions that we may consider in those cases too. The balloons for balloon sinuplasty, which got a lot of press over the last decade, is specifically used to manage that. People have tried to push it into the chronic rhinosinusitis realm, but the literature is not super supportive for that in the majority of patients. And a new entity, new meaning in the last 5 or so years, that's really come to light is the central compartment component of polyposis in the patients with chronic rhinosinusitis with polyps. So they are patients with CRS with polyps, but their polyps are limited in general to the central compartment. So it's polypoid degeneration in the middle turbinate and possibly the superior turbinate and even the nasal septum. And those patients have a very specific look on CT scan, and almost all of them test positive for an IgE-mediated atopic disease. So it's a very specific one, and the treatment for those people is different. They're not easier to treat. A lot of them are very refractory to a lot of the treatments that we offer, but it's important to be aware of those patients. So just in conclusion from our talk here, so chronic rhinosinusitis it's very prevalent and it can be disabling. There are many, many factors, including the anatomy and the mucociliary clearance and the patient's exposures that can play a role here. And it really impacts quality of life, more so than chronic back pain, CHF, and COPD. We touched on the multiple subtypes, and hopefully we touched on the fact that this is a relentless condition. And even though there are times when I think that I have a patient's problem solved, they come back 5 years later and it looks like they had never been touched, and we have to sort of reset things again. So these are people to not lose sight of as time goes by. I'm not sure if you have anything else to add, Dr. De La Hoz, but thanks everybody for your attention.
Thank you both for the informative presentation. Really appreciate that. As the doctors mentioned, if you have any questions that you would like to ask the 2 presenters, please do so in the question and answer box at the bottom. We do have several questions. One question: can blood eosinophil?
I can read it. Yeah.
Thank you.
Can blood eosinophil count be high in patients who have chronic rhinitis? Absolutely. Well, my patient had blood eosinophils should be up to 350 by absolute count. You shouldn't go by percentage so much. You get the count 350. Some people say 300, but whatever it is per microliter. So it should be drunk in the morning, by the way. There is a circadian rhythm to it, and manual counts are preferred. So I wanted to mention that. But that said, we often use the automated counts, and more than 0.3, which is what is usually reported, is considered elevated. My patient had 700 to 900. In the last year, I had a patient who went up to about 2,700. We actually still don't know. In his case, he's definitely very atopic. He was operated by Dr. Shohet, yeah. So we know that his passages are wide open perfectly and everything. And the eosinophil count was so marked that he actually was evaluated by oncology and had a bone marrow biopsy and all of that, and all malignancy was excluded. In the meantime, light bulb also kind of, he's on multiple medications, as it is the case with this severe chronic rhinosinusitis. He had traveled to his native Ecuador, but we excluded parasitic disease, which is another potential cause. And I removed Montelukast from his treatment, and he decreased to 1,300, which is still an elevated number, but certainly not, as scary as 2,700. So I'm in the process of observing him. He's off the Montelukast, and this is a segue to sometimes we as physicians underestimate the iatrogenic effects of some of our medications. And but so far, our working hypothesis is that it's a combination of allergic disease plus probably a reaction to Montelukast. So
one thing
that's an example.
One thing I'll add to that, the medical team at the Fire Department of New York actually did a study about 10 years ago on the initial presentation of a lot of these firefighters and the percentage with serum eosinophilia. And that predictor alone was positive in determining who would require further interventions, including sinonasal surgery longitudinally. So maybe they didn't require it right away, but over time, a lot of those people were the ones that leaned toward the need for further management of chronic rhinosinusitis. So I think that specifically supports that possibility as well. And
peripheral blood eosinophils are risk factors also for lower airway disease. Of course, that's more in my realm. Asthma and COPD both have high blood eosinophils as a risk factor. So in general, the take-home lesson is that it's something to try to characterize and establish the phenotype of both at upper and lower airway diseases. One thing to take into account is what their blood eosinophil count, and realize that because of the circadian rhythm, the test may have been drawn in different days. The patient may have been taking steroids and has suppressed their blood eosinophil count. So you have to be fairly methodic at looking at those results and recorded in the chart as a phenotypic characteristic of your patients, again, for upper and lower airway disease. It is a risk factor. Oh, there are more questions.
Yes, thank you. James Cohn question came in first, if you'd like to answer that first.
Michael, are there ongoing studies of chronic sphenoid sinus infection in the World Trade Center exposed population? We have a request to participate in such a study from one of our health registry enrollees. Sphenoid sinusitis, which actually I was suspecting in the patient that we presented because of she had, very weird headaches, and those headaches were kind of positional. She said that when she changed position at night, they tended to get better. And so that was one of the reasons also I was kind of trying to fish around for. So, but Michael, could you comment on sphenoid sinusitis?
Right. So I'm not aware, to answer the question specifically, I'm not aware of any ongoing study specifically for sphenoid sinus infection. I will say that there is a substantial component of sphenoid sinus involvement in the population, and there are certain circumstances where it's an isolated sphenoid sinus inflammatory thing. But most of the isolated ones that I have seen in the WTC population are of patients that presented after they had had some kind of intervention or surgery elsewhere. So I don't think that there's a very high, at least based on my exposure to this entity, a very high prevalence of patients presenting specifically with unilateral or bilateral sphenoid sinus opacification and no other sinuses being involved. But I do see a very high rate of patients where the sphenoid sinus is involved. And sometimes, and this patient example is a perfect one, where the patient had been treated, and most surgeons are not addressing the sphenoid sinuses unless they actually see mucosal thickening at the time of surgery on either the CT scan or directly. They're just not comfortable with that anatomy. There are a lot of very important structures there. My approach to chronic rhinosinusitis is different. We know chronic rhinosinusitis involves all the sinuses. We may not see it on a CT scan, but the same mucous membranes are exposed and vulnerable to all of those types of exposures. So in general, when I perform an operation, I address all the sinuses. That allows us to topically administer both antimicrobials or, more importantly, anti-inflammatories, or simply saline nasal lavage to all the sinuses to ameliorate their symptoms. So yes, I see plenty of patients with recurrent sphenoid infections. We very often need to operate on those people, but I don't know of a specific database for those people.
There is a question, Michael. I'll take the first part. Can you discuss when you would have treated with biologic agent instead of surgery or both, especially in patients like the one that we discussed? So I'll start with that because I was guilty of starting the biologic agent in her. We'll say that in general, Michael and I have very few patients on biologic agents, but and most of them actually have been already operated. So in my case, actually what happened is that I had an asthma difficult to control with swinging, lung function values, whose doctor was giving oral corticosteroids often, and who was on high dose inhaled corticosteroid plus multimodality leukotriene modifier, long-acting bronchodilator, overutilizing short-acting, etc. So at some point I wanted to stabilize that, and I thought, and she was hypereosinophilic, as I mentioned before, so I decided to go for benralizumab in her case to try to stabilize her a little bit, and it was after the fact that I started, taking a second look at the comorbidities and that a funny headache that she was reporting and the postnasal discharge, that I went, why don't we take a look at that, rhinosinusitis? Is it really as mild as she puts it? And that's how we discovered this sphenoid. But can you comment, Michael, in biologics and versus surgery, or the two together?
Right. So first
in your
of all,
practice.
So most of the patients in my practice that the biologics have either been prescribed by the referring pulmonologist or the referring allergist before I will have seen them. So a lot of the patients who I will operate on will be people that were refractory to the biologics along with the medical treatment. But there is a certain subset of people that even after surgery will see some relapse despite topical corticosteroids and whatnot, for which we will add the biologics post-operative. And we've had mixed success with that, but it's mostly been good. I think it's just important to understand it's a commitment to get biologics. We don't know how long a person needs to be on biologics for, and what the long-term side effects will be. We do know some of the short-term ones, and they're becoming coming more to the light as we go. Not only the ocular ones, but I think some people are developing some cough and other things related to them as well. So yes, they do play a role for sure. But I feel that many of these people, they will still require surgery in many circumstances and post-operative topical anti-inflammatories such as topical nasal steroids as well. And in fact, it's worth mentioning that most of these biologics, the FDA indication is as an adjunct. It's not the sole management of their chronic rhinosinusitis with polyps or asthma. So I think that's worth mentioning.
And as you know, we didn't extend over all these subtypes. Michael presented a layout of the different subtypes. When it gets to a complicated case with failure of medical treatment, you need to characterize. There may be a variant of the disease. We didn't want to mention, but for example, aspirin sensitivity is a very special case. One of my cases on biologic agent is somebody who has a very severe asthma, by the way, in fact, with fixed obstruction. But I was able to manage the airway disease. It was the opposite. The otolaryngologist, after the fourth sinus surgery, came to me because the polyps were coming back to try to put the patient on a biologic agent. And in fact, I did. And several years later, actually, she has not had recurrence of her polyps. And it took like a year and a half for her lung function to dramatically increase, but it did. It actually became normal. So just to give an example of the opposite situation where otolaryngology generated the urge to start something, and in that case was dupilumab, and the patient experienced a tremendous improvement of her upper airway, but also brought along her lower airway. About this rhinosinusitis, there's other comments, and it's definitely, you know, as I said, I was very motivated to look for that. I knew that this patient had already had surgeries with an otolaryngologist who was not a rhinologist. So for sure, he had not touched the sphenoid or the frontal, like Michael does, given his specialty training. So that was why, between that and the headaches, there was a famous New England Journal of Medicine article about sphenoid sinusitis and headaches. And yes, it can be associated with, you know, compromised you know, in the neurovascular anatomy, as one of the attendees actually presents. One more thing, one more word of caution, and Michael, you could extend on that, is that sinus CT is not the ultimate and only resource. There are cases where there are false positives and false negatives. Michael, could you mention something of that? I think that would be of importance to the audience.
Right. Well, first of all, I love the attention that people are giving to the sphenoid sinus, because I absolutely believe that out of all the paranasal sinuses, this is the one where if a person has findings, either mucosal thickening or opacification, I would say universally they are symptomatic. And almost always I recommend treatment for it. And the reason why is because the symptoms are not as obvious. They don't necessarily present with nasal obstruction. They may have this nagging postnasal drainage and they don't understand why. And we all know anatomically why that might be, because the natural outflow tract of the sphenoid sinus doesn't lend itself to anterior rhinorrhea. It all drains postnasally, and the people just notice this ball or of mucus in their throat. So they can be symptomatic that way, but more often they have these headaches, very vague. Sometimes they're frontal. The classic headache for sphenoid sinus is vertex headaches, but actually the majority of headaches with sphenoid sinusitis are frontal headaches. So headaches are a huge presenting issue. And then there are these vague neurologic complaints, including disequilibrium and vision issues. It's important to understand the anatomy that runs adjacent to the sphenoid sinuses. So the contents of the cavernous sinus, which include cranial nerves 3 through 5, all run, or 3 through 6, all run through that area. So it's important to realize that most of those are going to be involved in both our vestibular and ocular pathways. So I agree with the importance of detail for the sphenoid sinus, and I assure you that we do follow that pretty closely.
You can place any other questions in the using the Q&A function for those in the audience.
I do have 2 other questions that came in. Dr. De La Hoz and Dr. Shohet, as you know, in the World Trade Center Health Program, CRS has a 5-year maximum time interval. That is, CRS symptoms had to arise within 5 years of the last 9/11 exposure. And we're now seeing members who are presenting with CRS and claim that their CRS began within the maximum time interval. However, they're unable to provide medical records to support their claim as to when CRS began. And at their initial monitoring exam, there are no mention of CRS or related symptoms. Any thoughts on the likelihood that such a person has 9/11 related CRS?
Well, I am biased because I started seeing these patients 20 years ago. So of course I saw way more CRS that could clearly be related to the World Trade Center exposure 20 years ago. So, but I'm in the minority most of the clinicians that are seeing these patients are seeing them more recently than that. And they may feel inclined to, for example, if they see a case like the one that I presented, that's essentially underreported her symptoms to some degree and was being seen by a pulmonologist who ignored her nasal problems. Of course, she underreported them on top of that. And so it would be a level of comfort of whoever the clinician is that is considering certification to say that I would only re-emphasize that occupational rhinosinusitis usually precedes or is coexistent, co-synchronous with lower airway disease. And that has been validated in multiple studies related to multiple types of irritants, toxicants, pollutants, allergens. Is very classic. It's usually a predecessor of lower airway disease, or it happens at the same time, for example, with irritants, for example, ammonia, chlorine. It may, if the exposure is acute, both of them may happen at the same time. But with allergens, sometimes it's often a predecessor. So for somebody to appear at this point, and particularly without any other condition, you know, I can see how some clinicians would be hesitant to attest that that is as a causally associated condition, but it depends on the level of comfort of that physician. I have not certified anyone for sinusitis since 2012, and I use the 1 year, but the maximum that NIOSH accepts is 5 years. So.
Yeah, I can see both the suggestion that somebody may have been exposed and didn't present until much later, but probably had symptoms that they weren't aware of or didn't attribute to chronic rhinosinusitis, and then they present multiple years later. It's obviously a very difficult question to answer because a person could have developed their symptoms and their exposures following their initial exposures 20 years ago as well. So unless they have imaging or some sort of medical records to show that they did have findings, then I think it would be very hard to prove one way or the other.
Thank you both. And then the other question I have, this is a related but slightly different question. Is it possible for 9/11 related CRS to commence in 2024? That is, can a toxic exposure that occurred 20 years ago play a consequential and material role in causing new onset CRS that develops in 2024?
So I feel like all exposures that a person has had count for something. But I think that there are probably many, many more factors which prompted that person to present in 2024. The one thing that I think is worth mentioning, and Dr. De La Hoz had alluded to it a little earlier, was the entity of sinonasal cancers, because we know that the latency for sinonasal cancers is around 20 years. So I think it's important to not be dismissive to people that were exposed to WTC irritants that are complaining 20 years later of sinonasal pathology, because that could be an entity that needs to be evaluated.
I basically concur with that.
So thank you both for this very interesting webinar. Thank you for being so generous with your time and for so thoroughly answering the many questions that we received. So Dr. Shohet, would you mind stop sharing your screen? Because we're
Sure.
gonna now show a screen about how to get continuing education credits.
That's
so
important.
So we, at the CDC, we have a new system to get continuing education credits. So before we used a system called TCEO, that is basically no longer used. So the new system is called CDC Train. And I'm pleased to inform you that that CDC Train is an easier system to use. So to get credits for today's seminar, what you'll need to do is go to, and I've got the website here. So you could either take a screenshot of this slide, or you could just Google CDC Train. And then once you go to CDC Train, if you're not already registered, you'll need to register with CDC Train. And then to find the course, there's a search screen. You'll either type in the WC 4740 or the WC 4740 with today's date, 02/01/24. And then once you find the course, it'll ask you for the registration code, which is the World Trade Center Health Program. And then you should be able to apply or register for getting the credits. Once you do that, you'll need to take the post test. There's going to be 4 questions. You need to at least answer 3 of them correctly. You'll get 2 shots at answering those 4 questions. And then after you finish the post test, you'll be asked to evaluate the webinar. And then you'll be able to get your credits. And we're offering credits for medical, for physicians, nurses, pharmacists, certified public health professionals, physician assistants, and just general continuing education credits. And if you're viewing this recording, it's a little easier to find this course. You'll just need to type in, you'll still go to CDC Train. On the search bar, just type in WD, not WC, but WD 4740, and you should be able to find this rhinosinusitis seminar. So I think that's all we have. Does anybody else have anything they wanted to add before we close? Dr. Delahose or Dr. Shohet?
No, nothing else to add. Thanks again for allowing me the opportunity to speak with everybody.
Feel free to contact us. Michael and I have been working for 20 years. We don't admit it often. And so please send us any questions that might be, I mean, we are interested. We have an endless curiosity about this situation of these individuals. So thank you very much for your attention.
Thanks, everyone. Take care.
All right, so we'll sign off on this very important topic. Thanks everybody for joining.